Good afternoon, and good evening, or good morning, depending on from when and where you are joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to the CDC Public Health Grand Rounds for June 2016, Tracking Environmental Health Data for Public Health Decision Making. It's a very exciting topic, so let's get started, but a few housekeeping slides. Public Health Grand Rounds has continuing education credits available for physicians, nurses, pharmacists, and others. Please see the Public Health Grand Rounds website for additional details. We are also on all of your favorite social media sites, and we are live tweeting today. So please use hashtag CDC Grand Rounds for all your tweeting needs. We have a featured video segment called Beyond the Data, which will be posted shortly after the session. This month's segment features my interview with our first speaker, Heather Strohsnyder. We also have partnered with the CDC Public Health Library to feature scientific articles relevant to environmental health tracking. The full listing is available at cdc.gov/scienceclips. Here is a preview of the upcoming Grand Round session. Please join us live or on the web at your convenience. And in addition to our outstanding featured speakers, I'd like to take a moment to acknowledge the important contributions of the individuals listed here. Thank you. And now, for a few words from CDC's Director, Dr. Tom Frieden.
The environments we live, work, and play in contribute substantially to our health and well-being. For some health outcomes, being able to draw a clear connection between changes in our environment and the impact on our health has been easy. For other issues, there's a gap between the data and actionable evidence, but between what we know and what we do. To close this gap, in 2009, CDC launched the National Environmental Public Health Tracking Network. This network captures and combines data from national, state, and local sources and uses it to describe the intricate relationships between the environment and health. The tracking network is building the fundamental tool of public health in the environmental health area: timely, accurate, actionable surveillance information. The tracking network also uses new tools designed to help make better sense of the data and better share it with people who need to know. Today, CDC funds 26 state and city health departments to develop and operate local tracking networks. Many state and health departments have used this network to respond to concerns about environmental hazards and health outcomes in their communities. For example, the network has improved real-time surveillance and tracking of carbon monoxide poisonings in Wisconsin and other states, informed public policy to reduce melanoma in Minnesota, helped people in Kansas and other states reduce their risk of cancer from radon, and improved the quality of water, air, and response to heat waves in California and elsewhere. In the field of public health, we're increasingly embracing and acting on the concept of making data more widely available so it can be used by others and ourselves to inform decisions. This is particularly important in environmental health, where so many parts of society, both governmental and non-governmental, play critical roles that can either improve or undermine how our environment supports our health. Filling the gap between environmental data and health outcomes is critical. The tracking network is increasing the extent to which decisions about future directions in environmental health are driven by evidence and informed by health impact. Thank you.
And now, I'd like to introduce our first speaker, Heather Strohsnyder.
Thank you, Phoebe. Good afternoon, everyone, or I guess as Phoebe said, morning or evening, depending on when you're watching it. Let me start off very basic. Environmental health is a branch of public health that's concerned with the understanding how our hazards in our environment affect human health and the promotion of human health and well-being in a safe and healthful environment. Environmental hazards can be chemical, physical, biological, and they can be found in our air, water, food, communities, and homes. People can be exposed to environmental hazards by breathing them, touching them, or ingesting them. Outdoor air pollutants are one example of a class of environmental hazards. Air pollutants may be released directly into the atmosphere by human activity or from naturally occurring events. The Environmental Protection Agency, the EPA, regulates many of these outdoor air pollutants set forth by the U.S. Clean Air Act. National air quality standards exist for 6 criteria air pollutants and were developed using science-based guidelines. Of the 6 pollutants, particulate matter and ozone are the most widespread health threats and the most well-characterized. Air pollution is known to affect our health in many ways and can lead to a range of outcomes, including missed school or work, emergency department visits, hospitalizations, and even death. It can lead to negative respiratory effects like inflammation, coughing, wheezing, exacerbation of asthma or COPD, and lung cancer. Air pollution can impact our cardiovascular health, leading to abnormal heart rates, hardening of the arteries, and heart attacks. It can also impact our central nervous system, leading to strokes, and our reproductive health, leading to low birth weight, preterm births, and birth defects. In 2013, a global burden of disease study ranked ambient, or outdoor, air pollution as the 4th highest ranking risk factor for death globally. They found that 85% of the world's population lives in areas where air pollution is higher than the World Health Organization's air quality guidelines. One way we study the relationship between air pollution and health is to evaluate the association between daily fluctuation in air pollutant concentrations and daily fluctuations in ED visits, hospitalizations, or deaths. EPA relies on these studies to set standards for their 6 criteria air pollutants. Results from multiple studies are pooled to generate concentration response functions between an air pollutant and a health outcome, like emergency department visits for a respiratory outcome. The concentration response function tells us how many additional ED visits we can expect as air pollution increases. The most robust estimates are generated from large multi-city studies. Unfortunately, for ED visits and hospitalizations, EPA must rely upon results from multi-city studies of populations over 65 years of age using Medicare data, or single-city studies covering all ages, or international studies. Such research is also limited by temporal and spatial gaps in air monitoring data. Not every county conducts air monitoring, and not every air monitor samples air every day. The Pew Environmental Health Commission, in a 2000 report, identified a critical gap in knowledge that hinders our national efforts to reduce or eliminate diseases that might be prevented by better managing environmental factors. The reasons for this gap include: 1, a lack of data collected for many non-infectious diseases, despite the growing burden of chronic disease. 2, environmental hazard data collected for regulatory purposes, not for public health. And 3, insufficient data on human exposures to environmental hazards. Without these data, we are unable to answer important questions about the contribution of environmental hazards to adverse health outcomes. To address this gap, the Pew called for the creation of a nationwide health tracking network for diseases and exposures. In 2002, with appropriations from Congress, CDC established the National Environmental Public Health Tracking Program. Tracking, the verb, is the ongoing systematic collection, integration, analysis, and dissemination of hazard, exposure, and health effect data. Successful and effective tracking requires thorough evaluation of need, impact, and feasibility. To understand where to focus public health efforts, the tracking program, along with federal, state, and local partners, routinely determines the critical gap hindering public health action for a specific environmental health issue based on the state of the science and the state of practice. In 2009, CDC launched the National Environmental Public Health Tracking Network. The network is a web-based system of integrated health, exposure, environmental, and population data with public and secure components at the national and the state and local levels. It consists of gateways for securely transporting data and metadata repositories, toolboxes for data management and analysis, and public and secure portals for data access. The network is not specific hardware or software requirements, but rather a framework for functional standards. Standards such as the ability to allow public users query and visualize data. This allows a grantee to build upon or in line with the existing technical infrastructure within their agency. The network at the national, state, and local level can be and has been used to support other public health programs in data collection, management, analysis, and dissemination. But the tracking network is much more than the technical infrastructure and the data. It's also a network of people, a connected, multidisciplinary workforce of experts in programming, informatics, data science, along with epidemiologists, engineers, statisticians, and health educators. Together, they maintain, enhance, and ultimately use the tracking network to drive public health actions. To access the National Tracking Network, you can visit our site here. You can read about different health and environmental issues on the left, and you can access the data by clicking on Explore Tracking Data. You can also view data for your county only by selecting Info by Location. Clicking Explore Tracking Data launches the query panel that you see here. On the left, you can see a list of content areas for which we have data. To access the data, first select Content Area, Indicator, and Measure, and then the geography and years of interest. You can then explore the data in maps, tables, and charts. You can also share the query and download the data. You can access state and local tracking networks here. On grantee networks, you can find more state and local data on additional topics and data at a finer geographic resolution like zip code or census tract. Today, the tracking program funds 25 states and New York City to operate tracking programs and maintain jurisdiction-specific components of the network. It supports over 200 environmental health practitioners at the state and local level and has built partnerships between health and environmental agencies and between federal, state, and local levels. The tracking program and its network have made strides in significantly improving our ability to use data to inform public health actions. Our grantees have supported 341 state and local public health actions through the end of fiscal year 2015. And they have saved time and money at the state and local level by increasing data accessibility. To drive public health actions, we mean to detect and monitor trends, identify populations or exposures, to evaluate the relationship between health and environment, or to assess potential clusters. In order to improve, inform, or evaluate our programs, policies, or interventions designed to prevent or mitigate the impact of environmental hazards on health. Here's an example of a public health action. California agriculture produces nearly half of all fruits and vegetables grown in the U.S. However, agricultural production frequently relies on the applications of pesticides, which can be hazardous to public health, especially vulnerable populations like children. In California, little was known about the use of pesticides near schools. This map is from the pesticide program's mapping tool and shows pounds of pesticides applied by township. The darker the red, the greater the pounds of pesticides applied. The California Tracking Program examined the use of selected agricultural pesticides near public schools in the 15 counties with the highest level of pesticide use. The findings in the report have resulted in a statewide work group between government agencies, farmers, schools, and communities to develop new regulations for restricting the use of pesticides near schools. New regulation is expected in 2017. Other examples of public health actions include the use of blood lead data to inform new blood lead testing regulations for children in Maryland, the use of radon data results to inform home testing efforts, the development of an online tool to help residents judge the potential danger of smoke from wildfires, the establishment of city-level air monitoring to identify neighborhoods with high levels of air pollution in New York City, and the use of tracking data and expertise to conduct health impact assessments of proposed transportation and highway plans in Massachusetts. Another example of a public health action in progress takes us back to that lack of large multi-city studies on air pollution and ED visits among populations under the age of 65. First, to address gaps in monitoring data, Tracking has collaborated with EPA to develop a robust modeled data set providing daily estimates of ozone and PM 2.5 across the US. EPA provides us updated data once a year. Tracking has also collected ED data for respiratory outcomes from 17 states, and we are just now in the process of analyzing these data along with the modeled air data. For example, this histogram shows the number of days across 791 U.S. counties in 2012 by ozone concentration. For 25% of the days, ozone concentration was 49 parts per billion or higher. Conversely, for another 25% of days, ozone concentration was 31 parts per billion or less. Here you can see the percent increase in respiratory-related ED visits over a 7-day period following a day where ozone concentration was 49 parts per million versus 31 parts per million, with some assumptions like temperature and PM 2.5 concentrations remain the same. Ozone results in a 2.5 to 4% increase in ED visits for all age groups, with a greater increase among people under 65 compared to those who are older. Results of this study will address a critical gap in available information used by EPA to set their air pollution standards for ozone and PM. And now I'd like to turn it over to two of my colleagues from the state and local level who's going to tell you a little bit more about the tracking program and the utility of their network within their own jurisdictions. So it's my pleasure to introduce to you Dr. Wendy McKelvey to tell us about tracking in New York City.
Thanks, Heather, and thank you, CDC, for inviting me to present on how the New York City Tracking Program has advanced the use of data to drive environmental public health action. As the only local health department grantee, we play the important role of demonstrating the value of a tracking program locally. CDC tracking funds supported our health department in establishing a bureau dedicated to promoting use of data and the knowledge acquired from it to inform programs, policies, and initiatives in our Division of Environmental Health. The New York City Tracking Program built the Bureau infrastructure, which includes its staff of epidemiologists, environmental scientists, risk communicators, and GIS and informatics specialists. It includes the data we've amassed from our own and other agencies on health, exposures, and related behaviors. And it built IT systems that allow us to integrate, visualize, and share data both internally and externally. We also use data to educate people about environmental causes of disease. This is a screenshot of our public data portal, which provides access to many of the key indicators we use to inform our work. Strategies of the New York City Tracking Program have been to identify and augment sources of environmental health data, improve access to data through automated reports, portals, and dashboards, and we're continually analyzing and interpreting data in collaboration with stakeholders. In the early days of tracking, when we were taking inventory of available data sources, we saw a need within our traditional city environmental health programs that collected data but didn't do enough with it. One of our first internal collaborations was with programs that were working towards digitizing their inspections in the field. The tracking program supported this effort by building a centralized data warehouse that made inspection program data easily accessible for analysis and reporting. And we now routinely create and share reports that allow program leadership to track performance and better target their limited resources. I'll describe now some initiatives that grew out of this expanded use of data from existing programs. The New York City letter grading program uses publicly posted grades to communicate inspection findings, and it applies a schedule of more frequent inspections to the poorest performers. Inspection data is pulled into our centralized system, and tracking program staff analyze it and report on it to inform program operations. Rat indexing is a program that canvasses the city systematically, block by block, looking for signs of rats, and inspectors place bait where rats are most likely to be instead of only where complaints come from. As with restaurant food safety, rat inspection data is pulled into the centralized system, allowing analysts easy access for reporting to guide program operations. More recently, we've used data on child care center placement and capacity to inform expansion of services in the current mayor's Universal Pre-Kindergarten Initiative. And finally, daily monitoring of call data from the Poison Control Center guides staff in conducting outreach to areas least likely to call to make sure all New York City residents are aware of this important resource and know how to access it. Tracking infrastructure has also strengthened environmental emergency response in New York City. Just after Superstorm Sandy, we did not anticipate the number of people who would be sheltering in place in buildings without power, heat, or water. Since that time, we've used our analytical and GIS expertise to support an electronic data capture system to assess residential building damage that could occur again if a similarly powerful coastal storm hits. We've also leveraged our experience centralizing data from routine field inspections to improve upon a plan for health and safety surveillance of evacuation shelters that are open during certain emergencies. And since the mosquito season has started, we've been using tracking IT and GIS expertise to inform the public about mosquito control efforts to minimize risk of Zika and West Nile virus. We populate a public website daily with notices of pesticide spray events, and we provide a map of spray locations. Now I'll describe 4 environmental health initiatives that did not grow out of existing programs, but rather took root and became success stories with support from the tracking program. In 2008, New York City launched a community air survey to monitor air quality at high resolution across neighborhoods and to identify important local sources of pollution. It's been so well received that last fall, the New York City Council passed a law requiring it to be ongoing. Local air monitoring identified residual heating oil, often used in older buildings, as a major determinant of sulfur dioxide and fine particulate matter pollution patterns across New York City neighborhoods. This finding supported a rule now in effect to phase out use of residual heating oil in all buildings. And by bringing local air pollution data together with local tracking data on related health effects, we've been able to estimate health benefits of air pollution control, and we use these estimates to prioritize highest risk neighborhoods for boiler switching and energy efficiency upgrades. These graphs show the 70% decline in average winter sulfur dioxide air pollution between 2008 and 2014. The phase-out of residual heating oil is one reason for the decline, in conjunction with state regulations to reduce allowable sulfur content of heating oil. Reducing use of toxic pesticide products is a signature aim of the New York City Tracking Program. Early on, we acquired data from the New York State Pesticide Sales and Use Registry and found that the quantity of pesticides used in New York City rivaled use in agricultural areas of the state. We were especially concerned because pesticides used indoors are in close contact with residents and more likely to persist in the absence of light and weather. Integrated pest management is a safer and more effective alternative to conventional spraying. IPM controls pests by depriving them of food, shelter, and water. It uses minimal amounts of the least toxic chemicals applied directly where pest problems originate, rather than indiscriminately applied throughout the home. One of the earliest tracking program collaborations was with Columbia University on an intervention study of IPM in public housing. We published a manuscript suggesting that IPM reduces pest counts more and for a more sustained time than conventional methods. And in 2005, we used our data, our findings, and our knowledge to promote passage of Local Law 37, which requires all city agencies to use IPM wherever possible and to eliminate use of products that may be carcinogenic or reproductive toxicants. The New York City Tracking Program works closely with our Climate and Health Program, which is supported by the CDC Climate Ready Cities and States initiative to improve resilience to climate effects. Back in 2008, tracking data was used to identify a more appropriate threshold for heat advisories in New York City based on actual observed heat-related health effects. We used tracking data to target messages about heat to the most vulnerable neighborhoods. The map here displays an index that was created from an analysis of deaths during past heat waves. We track population access to air conditioning to support the climate program in advocating for increased access to vulnerable groups, and we've recently begun to provide data to support a study to assess potential health impacts of power outages. On our public data portal, we bring key climate and health indicators together in a neighborhood-based report that can guide community priorities for increasing climate resilience. The indicators in this report are from a wide variety of data sources, ranging from local health surveys to the U.S. Geological Survey. My last example is about our efforts to reduce exposure to mercury. In 2004, the New York City Health Department conducted a local health and nutrition examination survey, similar to the national HANES, of about 2,000 adults, and we measured mercury in the blood and urine of participants. This figure displays estimates of blood mercury levels of 5 micrograms per liter or higher, which is the New York State reportable level. We found that the overall New York City estimate of elevated levels was 2.5 times the national estimate, and almost half of Asians had reportable levels. We analyzed the data to better understand the source of exposure, which is typically fish when blood levels are elevated. We identified foreign-born Chinese New Yorkers as having especially high blood mercury levels, and you can see here that almost 1/4 of this group reported consuming fish 20 or more times in the last 30 days. These findings led to an outreach effort to encourage the highest risk groups to choose fish lower in mercury. The developing nervous system is most vulnerable to mercury exposure, so we targeted our outreach to pregnant and breastfeeding women and those who care for young children. But fish also contain nutrients that are beneficial to the developing nervous system. So we developed a brochure to emphasize that people can and should keep eating fish, but higher risk groups should choose lower mercury species. We released our message to the press and to healthcare providers through an electronic messaging system, and we've distributed hundreds of thousands of copies of our brochure in English, Chinese, Japanese, Korean, and Spanish, and it is available on our website. These are just a few articles that appeared in the New York Times after we released our findings. Tracking program staff also analyzed urine mercury levels, which typically reflect exposure from sources other than fish. We identified some very elevated levels in women, mostly Dominican, who reported using skin lightening creams. This is an image of one of the products we confiscated from a study participant. You can see ammoniated mercury is a principal ingredient. Our findings led to extensive outreach and education about the danger of mercury-containing skin lightening creams. I was on the job about 2 months when I remember attending then Commissioner of Health Frieden's bilingual conference with the vice consul from the Dominican consulate warning people about the products. Shortly afterwards, we canvassed stores in Dominican neighborhoods where we identified and embargoed hundreds of products that listed mercury as an ingredient. We conducted a second New York City HANES in 2013-14, which provided an opportunity to see if our and others' work to reduce exposure to mercury have been successful. Preliminary analyses we've done suggest that they have. Looking towards the future, we'll continue to use state-of-the-art IT to bring together and analyze data that can inform existing environmental health programs, including food safety, childcare, pest control, poison control, and emergency response. And we'll continue to promote use of data in collaborations to improve air quality and increase resilience to extreme weather events, reduce pesticide use, and more recently, to support the current mayor's Vision Zero initiative to reduce traffic deaths and injuries to zero. And we have other ideas brewing as well. So I thank you, and now I'd like to introduce our next speaker, Jan Sullivan.
Thank you, Wendy. For my presentation, I've chosen to share with you some expansive and impactful applications of Massachusetts tracking that reflect the department's goal of health in all policy. Tracking grantees have moved through this continuum from portal development to data utilization, where, as Wendy and Heather have previously talked, we've developed nationally standardized measures enabling regional and national environmental health assessments, where each grantee has enhanced its capacity to address local environmental health issues. Grantees have all moved into a data utilization stage, where we had originally set our sights since first initiating tracking. My example applications fall into two categories: health surveillance and policy. For health outcome surveillance, the Massachusetts focus is almost always at the community and census tract levels. Historically, our residents and other stakeholders have looked for and used data at smaller than county geographic levels for program planning and evaluation, even when giving attention to national issues like lead in drinking water. I have 3 examples of surveillance data utilization affecting local and state policy. The first is our development of community health profiles for each of our 351 cities and towns. Rather than solely provide detailed health and environmental data that can be queried by content area on our public tracking portal, we wanted to also pull selected data sets together, along with elements of data interpretation, to give residents and decision makers a fuller vision of a community's environmental health status. Each profile is 10 pages with the goal of focusing attention on needs and opportunities for local and state primary prevention efforts. Descriptive information on the community sets the stage, followed by various environmental and health indicators, concluding with prevention information and other resources. We start with demographics, including race and ethnicity, then move to health issues. This page presents lead screening results for children. One important element of our profiles is that the messaging guides interpretation. Here, we present the rate of heart attack and asthma emergency department visits. The data presented in these profiles are automatically updated when new data are uploaded to our data warehouse. Here's air quality data for Boston, drinking water quality data, including lead exceedances, and information on Boston's climate change vulnerabilities, our data sources, where to obtain further information, and on the last page, a glossary. A second surveillance example looks at blood lead data in children. This slide is an example of output from our blood lead dashboard, here showing a number of metropolitan communities in Boston. The dashboard is a component of our secure or non-public portal, its goal being to apply our blood lead data to automatically identify spikes in incidence exceeding a statistical threshold that could trigger corrective actions, such as evaluation of drinking water corrosion plans or case management activities. Our secure portal warehouses our individual level data, such as blood lead, cancer incidents, and birth outcome reports. A related activity is the development of a community-led report card. The report card is generated automatically as data are uploaded to the portal. We plan to provide these annually to our local boards of health, pediatricians, and other partners. Even more so than our community profiles, the lead report card is targeted to influence local policy to prevent lead exposure by increasing screening rates in high-risk populations, lead inspections, and the number of homes being de-leaded. The back page of the report card provides maps, here of Boston, of blood lead prevalence and screening by census tract to aid in targeting vulnerable populations. We also have a public database on home inspection results by address. The third example of surveillance data utilization provides a map view of identified census tract level populations vulnerable to heat events. Other data views we're developing will include additional social determinants of health and the results of predictive modeling of future impacts. Our climate change surveillance data inform preparedness efforts of local health and are being used to develop school curriculum to enhance awareness. Moving from data surveillance to the policy impacts of tracking, an important observation is that the inclusion of health data in policy is largely because, for the first time and as a direct result of tracking, health and environmental data are accessible to our stakeholders. I've divided the health and policy data utilization examples into two categories: environmental policy and community health policy. Health impact assessments are one example of health impacting environmental policy. In Massachusetts, a Healthy Transportation Compact was formed, whereby multiple state agencies agreed to collectively implement the compact with the goal of developing methods and conducting health impact assessments that include health data for air, rail, and road transportation projects. The inclusion of health as a part of formal policy is a major step forward for environmental policymaking in Massachusetts. This pathway diagram is an overview of the health impact assessment planning process for transportation projects. Adapted from CDC's Health Impact Assessment web content, these pathways help the end user make the connection between their project and potentially relevant health impacts. One specific Healthy Transportation Compact project is called Grounding McGrath. McGrath being an elevated highway in the Boston area that's shown on the left. This slide is meant to illustrate how the consideration of health and the inclusion of the public's voice through the health impact assessment process have directly led to the proposal on the right, where community design is considering the reduction of exposure to air and noise pollution and the promotion of opportunities for physical activity in the development process. I want to also highlight that Massachusetts is going beyond just the support of the health impact assessment process by currently developing a tool for health impact assessment practitioners to directly access tracking data based on the types of health impact assessment projects and to include social determinants of health data. In a highway project health impact assessment, the tool will identify relevant vulnerable populations such as children and health indicators such as asthma and provide them for consideration with environmental data. An additional feature of the tool is the inclusion of a mapping function that creates custom geographies at the census tract or community level in accordance with the geographic specifications of the project. In this map, the red area represents the geographic focus of the highway project, and the green area represents the affected census tracts for which the social determinants of health and other health data would be extracted from the tracking portal. A second example of an environmental policy driven by the availability of tracking data is in Massachusetts' environmental justice policy. There has long been interest by government and advocacy groups to include health in our environmental justice policy. Recently, a revised policy went out for public comment, and it included a new health criteria in the actual definition of an environmental justice population. After careful analysis, we realized that the addition of health criteria in the definition itself was not consistent with the intent of environmental justice to ensure that all populations have a voice in environmental policy decision-making. Adding health into the definition could favor ill populations already with a voice over minority and poor populations. So our department instead proposed a two-stage environmental justice policy where the more broad environmental justice definition remained essentially as it has been, but health data would be added to identify and prioritize vulnerable environmental justice populations. This map illustrates the current EJ populations in metropolitan Boston. The different colors reflect the different criteria contributing to the population's status as an environmental justice population. The new stage proposed in the policy by the Massachusetts Department of Public Health would require the use of selected tracking data, such as low birth weight and asthma data, to identify vulnerable populations. Both health impact assessments and environmental justice policies engage public stakeholders in environmental decisions and projects. Historically, environmental justice policy did not always result in public voices being heard, particularly if an environmental regulatory standard was not exceeded. The inclusion of tracking health data, as proposed by our department, could significantly increase public participation in a wide range of decisions related to projects with potential environmental health impacts. This last example I'll share is of Massachusetts tracking data used to drive community health policy. You may be aware that every 3 years, hospitals must identify the health needs of the communities that they serve, and importantly, implement strategies to address those needs within the community. Tracking offers much of the data that hospitals and others conducting community health needs assessments have struggled to obtain. Data that can more clearly identify needs than previously available, and data that can be used to evaluate intervention strategies. Massachusetts has entered into a collaboration with hospital coalitions to identify health indicators of interest. We're collaborating with other departmental bureaus to receive additional indicators, such as diabetes, stroke, and behavioral risk factor surveillance survey data. The tracking program is creating another tool to meet the needs of hospitals using our tracking portal infrastructure. Here is a view of the Community Health Needs Assessment tool's initial query selections, showing choices by community or hospital service area. Here's one example of the output. Thousands of lines of data are potentially available. With this tool, we provide the functionality for viewing the data by social determinants of health and for custom-created geographies, similar to our health impact assessment tool. What I've shared with you are just a few examples. It's not an exaggeration to say that tracking in Massachusetts is overwhelmed with requests from our governor, our commissioner, other Department of Public Health programs, state environmental agencies, other stakeholders for the applications of tracking data to guide policies and inform decision-making, all because environmental health data are now accessible through tracking. And I believe we are only touching the surface of tracking's potential. Thank you for your interest, and I'll turn the podium back to Heather.
Well, thank you, Wendy and Jan, for being here today and for sharing with us how tracking has improved the utility of data to inform state and local environmental health decisions. These two presentations represent what tracking means for all of our 26 funded state and local health programs. Together, we've been able to improve the availability and the accessibility of data, and we have been able to standardize those data in a way that allows us to monitor trends and patterns across the U.S. and over time, and to respond to those state and local concerns. And we really have come a long way since 2002 when this program began, but as Jan said, we're only touching the surface on this program's potential. I know I can speak for others in this program when I say I'm very excited to be part of this program, and I'm very excited to see this program continue to grow. It is truly a collaborative program in support of the many vital environmental health programs here at CDC as well as at the state and local level. Tracking is not an out-of-the-box software solution. It is a philosophy for conducting environmental health in a data and informatics-driven world. So please visit our website and learn more about applying tracking's data and expertise to your environmental health decision. So with that, I would like to thank you all for your time and attendance today and open the floor for any questions. We will be taking questions from the public online first, before the folks in the room. And please be mindful of other participants who have questions and keep your questions brief and actually questions when you step up to the mics in the back of the room. So with that, we'll take questions.
First question from our Twitter followers. Wondering if the Environmental Health Tracking Program will collect micro-enviro data. In restaurants, enviro factors matter in food safety and public health.
That was micro-enviro factors?
That's what it says.
Not sure how to interpret that. But more broadly speaking, taking a step back, is that when it comes to conducting surveillance or monitoring, we have to be strategic about where and how we employ that. It would be difficult to have widespread monitoring in every restaurant. So I think for restaurants, we have systems in place that help us identify those types of problems.
Right, exactly. And in New York City, what we're monitoring in restaurants are the conditions, the contributing factors, the environmental antecedents that lead to contamination of food. Our inspections programs are complex. They have long checklists of items to check to make sure that food is safe from contamination. Outbreaks are investigated and sources are identified. And of course, this is all with the data that we've been emphasizing is so important, to make sure that we are efficient and effective with our boots on the ground environmental health programs.
Any questions from anybody in the room? There are mics. Well, you can use the mic also in front of you.
Okay, thanks. I noticed, Dr. McKelvey, in your presentation, you said that pesticide use in New York City rivaled the use in agricultural areas. Can you say why? I was guessing that it was bed bugs or rodents, but...
There is a lot of insecticide use that goes on to control cockroaches and other, insects, rodent control, fungicide application. If you visit our portal, we actually show the quantity of pesticides used commercially that's been reported to New York State through the Pesticide Sales and Use Registry. And you can see it's a lot. Controlling pests in an urban environment is a challenge. So that was a finding that was a surprise to us, and it really argued for doing something about it. And hence our promotion of IPM and our restriction of city agencies, to not use the more toxic products.
Okay.
Dr. Bricey.
Thank you very much for great presentations. So it seems that there's a universe of potential problems that could be addressed by tracking, and there are probably not enough resources to include all of them in a tracking platform. So I'm wondering if Wendy and Jan, you can speak to how you work at the state and local level to prioritize what could be most important, what could be most valuable to take on next.
Part of I guess it's kind of a two-prong approach, I guess. Our commissioner sets departmental priorities, and one of her key interests and commitments currently is to reduce health disparities. So along the lines of building our capacity to look at social determinants of health, that will help address disparities, as well as strengthening our environmental justice policy. So part of our work is driven by departmental commitments and interests. And then we also have a state advisory group that we meet with twice a year. And for example, our community profiles came out of that work group. That we had a number of representatives from local health in that group, and they said that they really wanted to see a snapshot of their community. So I think it's a combination to set priorities.
And I would emphasize the importance of health impact assessment, the kind of quantification of health impacts that really are so important in driving what our priorities should be. You know, so for example, remember Heather's slide on air pollution and the deaths worldwide. It's a lot. I think people don't realize that you know, there's concern about often, you know, exposures that maybe don't rival the impact of air pollution, for example. And conducting the health impact assessment helps to quantify, you know, the magnitude of these problems to argue for, okay, you know, this is something we really need to focus on. Same with the climate effects, extreme heat. There are health effects that I think are not as recognized, but with the data and health impact assessment, we're able to communicate that better.
I guess I would add just one other thing, and that is that we do try to, I guess, capitalize on other programs within the Bureau. And that includes our climate and health work that is funded by CDC. We also are building some information onto our portal in the next year or so related to exposure to hazardous chemicals. And that is driven by the work that we've done through our ATSDR cooperative agreement within CDC. So I think that, you know, to gain some efficiencies, we've got work going on in other program areas, and it all seems to lend itself to tracking and to strengthening tracking. So we're trying to do that as well.
Any other questions?
So with these wonderful examples of the benefits to the tracking grantee states, is there a possibility or desire to expand the number of states?
Well, we are certainly very eager to continue to grow this program and its capacity, not just within the existing states, but across the country. We do host a fellowship program with ASTO, which is the Association of State and Territorial Health Organizations, where we've been able to offer fellowships to states and counties and state cities that we don't currently fund to help them sort of get introduced to tracking and start applying the tracking concept to their environmental health decisions. So we're very eager to do that. Yes.
Do you have any tribal partners in the tracking program at this time?
We do actually. At the national level, we have a project involving, I'm looking at Alex, it's the Great Lakes, GLITEC is the acronym. It's the Great Lakes Intertribal Epicenter that we've started up at the national level. But several of our grantees have projects going on with tribes within their own states or jurisdictions. Any other questions, please?
Thanks again for an outstanding set of presentations. Follow up to one of the prior questions. So for state or local public health staff interested in these issues who are working in a non-funded, a non-grantee state, are there data portals or other places they can go to try to at least get a handle on what might be the priority environmental health issues they should be tracking at the state or local level?
Yeah, absolutely. So we actually have had many unfunded state partners who have been involved in tracking and, for instance, even submit data from the state health department to the national level. And at the national level, on our national public portal, anytime data are already available centrally or federally, we obtain the data from that resource, and we obtain data for all states, not just the ones that are funded. So there are data available for all states for some of our conditions up on the national portal. But this program, like I said, it's not as if it's a software solution or hardware or something you buy. It is a concept, a framework for conducting environmental health surveillance, and that is something that unfunded states can join us in at any point, where we have a guide for helping them getting started. Some of the first things is really taking an assessment of the technical infrastructure within your state and understanding the data resources that are available and understanding what are the state and local priorities. So we do offer a framework for that and welcome any state, county, or city who would be interested in collaborating with us. Yes.
Hi there. 3 great presentations, thanks. This is a question for Heather. We saw 2 state and local presentations that were chock full of action and public health impact. So I'm wondering about all of the grantees. To what degree is CDC either encouraging or thinking of what CDC could do to focus all the grantees to be so action and impact oriented?
Well, I think that they really are. So from the very beginning of the program, we've been interested in tracking what we call these public health actions. So where we've been able to use data in support of programs or policies or interventions, and we've been tracking that all along. And at this point, we've got 341 reported, and that's from all of our grantees. And that really is just what's reported, a snapshot of what's going on. And there's, I would say, we could have brought up 26 different programs and had pretty lengthy presentations as well. So, and I think that's one of the good things about this program is it's about, again, it's about how to conduct environmental health surveillance, and it's about establishing core competency and functionality, both in a public health professional sort of way and also in a technical infrastructure, and then applying that to your state and local health issues. So I would say that all of our programs are as equally.
Okay. So it's not just tracking process, it's action impact for all the grantees. Okay,
Correct.
That's great.
Correct.
Thanks.
Correct. And we really have been, Jan's slide kind of alluded to, the first few years was really capacity building and piloting, taking that sort of assessment. Then it was building that technical infrastructure, centralizing our data sources and cleaning it up. And then it was like building the portals and disseminating the data. And we've been really focused this last couple FOA cycles on using that data. So we're really focused on that endpoint. Yes.
This is from our Grand Rounds email box. Could you talk more about how CDC is working with other federal agencies in addition to EPA to collect data?
Of course. So we collaborate with internally with other CDC programs. We obtain cancer data, for instance, from the National Program of Cancer Registries, and we also work very closely with birth defects. In fact, I think some of our grantees at the state and local level have been able to support birth defects surveillance. So they're a very close partner of ours at all levels of government. And of course, then Vital Statistics, the National Center for Health Statistics. We obviously work with them as well in obtaining those data that they have. But we also work with organizations like NASA or USGS to obtain satellite data that can help us understand air pollution or climate or weather. And USGS, it's mostly with groundwater contamination. Any last questions? Dr. Bricey.
One more, I could ask a lot. But the public access is, I think, a crucial component of this. And do you track the public access and/or do you have outreach programs to make the public aware of this information in terms of knowing what's in your environment? The more you know, the more you learn, the more action can come from that, the grassroots stuff can grow. How do you drive the general public to this data source?
So an important component of the program has always been that awareness and outreach. We have staff dedicated to that aspect of it, both in the sense of understanding, both in the sense of reaching out to people to bring them to the network, but also in understanding what their needs are and how we can best deliver data to their specific issue or concern. So we have a number of different sort of campaigns, targeting different groups that need data to make those types of decisions. And all of our networks are set up so that they can track the number of people who visit our site, what they're looking at, what they're querying. So we do have that feedback loop where we can see what data is being used most frequently, and maybe what data needs to be tweaked. And we do track those numbers. Mm-hmm.
I guess I could. Whoops.
No, you. Yeah.
In Massachusetts, I guess I could add that I alluded to our 351 local health departments, and we do quarterly training with them. And I think at every session we have at least one presentation or demonstration of tracking because we are really keen on promoting it for local health agents.
And in New York City, we also track, of course, the use of our online materials and materials developed through, with support from the tracking program. For example, the brochure I mentioned on fish, which was so popular, and yeah, literally we're up to hundreds of thousands distributed up to now. And we have many materials that the data support, and we track distribution of those.
I'm sorry, we've reached the end of the hour. If you would please thank the speakers for their excellent presentations. And thank you so much for coming, and we'll see you next month.